we design our health systems almost in ways to exclude important segments of our population who need it most. And we need to look at how we create structures to meet people where they are. And the technology exists for us to do so. We need to change our mindset from we'll build it and they will come to a mindset where we provide rich people where they are. And that has to be very important.
When I learned about cardiology, I learned about the traditional risk factors, and they talked about, well, hypertension and African Americans have more hypertension and Native Americans have more diabetes. And that's the reason that they have higher risk of cardiovascular disease. But in fact, the prevalence of obesity, diabetes, or hypertension have roots in things that have nothing to do with biology or genetics. They have to do with redlining and living in neighborhoods that have poor access to safe exercise and physical activity and food safety. What mother chose to live in an unhealthy environment? She did not. There are generations and generations of reasons that her people and her family were not allowed to buy or rent in places that were safer. And so if we take several generations back and consider how hypertension, which we know that the risk of hypertension is increased among those who have experienced racism. There are studies that have been able to show that actually the experience of racism increases cardiovascular disease risk and risk factors.
I think of Mayo in Arizona's relationship with Phoenix Indian Medical Center, for example. So we send medical oncologists there to see cancer patients, particularly breast cancer patients, to help deliver care there. And some of those patients then wind up coming to us for care as well. And so I think there is a responsibility for those who have more resources to share those resources with the community. Really, participation in clinical trials really revolves around issues of equity and disparities. And so in order to make advances in bringing down some of the morbidity and mortality or suffering and death from diseases, we do need everyone to be represented in clinical trials. Clinical trials often allow patients access to cutting-edge therapies that can be life-changing and life-saving in many instances. And so to not have people participate in clinical trials in some ways lessens their ability to potentially get life-saving therapies.
If we look at the patients with triple-negative breast cancer, just that disease, and there's a differential in outcome between the whites and the Black population. So we think that most of the difference in outcome, it's probably not as important in terms of biology. We don't know yet. We're still looking at this, but it's a matter of, are they getting access to going to the clinics where treatment is available? Are they seeking care early enough? Because the earlier we can diagnose a cancer, the better the outcome. So look at that discrepancy. The reality of cancer, median 66 years. The reality in clinical trials is about 50 to 52 years. This is a gap that we have to continue to close, because we need to, after we complete the clinical trials, to understand how the older or the younger populations, and this is not talking about race at all, it's about ageism that exists as a discriminatory factor in this world. We need to understand safety and efficacy for the older population, because they are the ones who are mostly affected by this disorder.
One thing that is in national consciousness currently is the issue of algorithm bias, right? These AI things that we use in driving medical care. And it is more pervasive than you think, right? And it's a lot of bias either built into the instruments or to the algorithms that are developed in populations that don't include enough diversity, to the extent that when you now use it in everybody, including African-American, Latinos, and other groups, it creates disadvantage, reinforces disadvantage, and could make it worse, make it less likely to get to healthcare soon enough.